Hello everyone, good evening. Thank you so much for joining me tonight. We've had so many wonderful new friends joining us in the last couple weeks as we have been focusing on specific clinical disorders like Parkinson's disease, myasthenia gravis, Alzheimer's disease, and mixed dementia. I wanted to pick a topic tonight that was going to be relevant to a large group of people. So we're going to be talking about the dangers of cognitive screening measures. We're going to talk about the problems that are associated with them, and of course we have to offer a solution for how we could be doing things better. I want to remind you all who I am. My name is Dr. Karen Sullivan, and I am a board-certified neuropsychologist. I have a private practice in Pinehurst, North Carolina, and I have a program called I Care for Your Brain with Dr. Sullivan, and you are joining me in that program tonight. I go around to different continuing care retirement communities in North Carolina and offer lectures to empower older adults about brain health. And starting in October, I decided to extend my reach to Facebook, and it's been a really positive experience. I think exactly like I thought. People were out there really craving high quality information from someone that they could trust, that was not selling them a product, that was here truly to share knowledge and information. So thank you guys so much for joining me tonight. So let's get started talking about our topic. Why is it that somebody might be in the process of getting a cognitive screen? Well, it's always because someone in their life, either themselves or their family or a physician, a medical provider, is concerned that there has been a change in the person, either in the way that they're thinking, the way that they're feeling, or the way that they are behaving. The essential question that we're trying to answer with cognitive screens is, are these changes related to dementia? Dementia is a clinical syndrome that, of course, yes, has cognitive symptoms, but there are also two other areas of functioning that are always impaired in dementia. And it's very important that we talk about these because this is great knowledge if you or somebody that you care about is worried about maybe having dementia. So in addition to the cognitive symptoms, which typically include difficulty with new learning, trouble with short-term memory, difficulty with things like multitasking, solving complex problems, finding their words, paying attention to a lot of different things at one time. There also is always mood and behavior changes, and these have to be significant to the point that they interfere with everyday life. So we never want to forget that dementia also has these mood and behavior symptoms and the everyday life component, because that is what has to come together to be consistent with the diagnosis of dementia. So in mood and behavior, what you typically see, and these symptoms can actually happen ahead of the cognitive symptoms, so even before we have difficulty with learning and short-term memory. We can see that people just aren't acting like themselves. They're not as interested in things as they once were. Maybe they're a little bit more irritable. They're just seeming kind of distant, which can also then over time, when it is dementia, progress into things like a lot more anxiety about being left alone, things like paranoia, when somebody misplaces their purse but they don't remember that they actually put it somewhere but can't find it. The logical thing that the brain does is it kind of fills in the gap, and the person really believes that somebody maybe came into their house and stole their purse. So we always have this going on. And we always have an everyday functioning piece. So the most common thing that you see in early stage dementia is trouble with complex finances. This is why after tax time, my practice gets really busy, because sometimes we can kind of coast throughout the year, but when we have to get together complex documents and we're having to get investments together, it can really become apparent that someone's having a problem. Things like balancing a checkbook accurately are not possible when someone has anything more than a very mild dementia. So that's a great rule of thumb for you all out there to know. If you're worried, look to everyday life. So many times I get a difference of opinion during my clinical interview when people come to see me when they're worried about memory, and a husband will be saying, oh boy, there's definitely a problem, and the wife will say, look, you really shouldn't pay attention to him. He doesn't even spend that much time with me. He doesn't know. And I always appreciate getting to be the objective evaluator of the truth, because the truth probably lies somewhere between what both of these people are seeing and thinking, but we really do need to rely on objective measures of cognition, and that is our focus tonight. I want you to remember that not all complaints about memory are going to wind up being consistent with dementia. Okay, there are all sorts of other things: depression, anxiety, post-traumatic stress, effects of medications, alcohol. People can sometimes have something that we call secondary gain, which is, the truth is, on some level they need and crave the attention that comes along with being sick. Sometimes people can do that physically, but also those same symptoms can happen in the brain, and people can get very, very worried to the point where they're misinterpreting everyday little cognitive blips as maybe being due to dementia. So this is a very complex issue. This is why it takes an hour-long interview as a neuropsychologist, 2 to 3 hours of paper and pencil testing, and about another hour of reviewing medical records and talking with referring providers to come up with the answer about what is going on. The other important thing you need to think about is that I've never ever seen a case of dementia that the cognitive impairment and the difficulty in everyday life was just related to dementia. People with dementia also have many other things going on that can impact cognition. So I often think of kind of like a layered cake. That yes, maybe there is one layer that is related to dementia, but there also could be other layers that are treatable. And if we can treat some of the layers, then maybe the severity of the dementia will not be as serious. When dementia is not diagnosed early or accurately, people are losing valuable time. And this is why I get so worked up about these screening measures, because it really, really matters that people get diagnosed as early as possible and as accurately as possible. So when this doesn't happen, there are very serious anxieties that are going on typically in the family. So in some types of dementia, like Alzheimer's disease, the person themselves is actually not going to be aware of what's changing, so they're not going to be worried. This is actually a neurological phenomenon called anosognosia, and it is just as real as the trouble with short-term memory that people with Alzheimer's have. So the person themselves may not be worried, but their family member may be very worried. And when they don't have a doctor that can help them and help to interpret the symptoms and help understand what does the future hold, what is it that we're supposed to be looking out for, what should we be doing, how can we help, people's anxiety increases. And this is not okay, because this is further reducing quality of life problems. Without an accurate and early diagnosis, people cannot receive the education about their condition that people so desperately need. Case in point, why we're here tonight, because I know that people are out there craving, desiring, desperately wanting knowledge. It shouldn't be this hard to find it, right? But my impression is that the way the modern medical system is set up is that we are left with so little face time with our providers. And so many times people are leaving evaluations about the brain, especially when these cognitive screening measures are being used, with virtually no information. And they're having to go on the internet themselves to figure things out. But you need someone who is trained, who is compassionate, who is interested and knowledgeable to convey this information to you, or you're going to maybe miss something that's important. Maybe you're going to overinterpret something that's actually not that important. We need to be able to support families in important decision making. The first thing that comes to my mind with dementia is the decision of when to cut back or to stop driving. If there is not a medical provider helping a family make this decision and communicate this decision, so many times families can become the bad guys, okay? So this is concerning because people who are living in a family with someone with dementia have enough problems, okay? They don't need to also be public enemy number one because they are taking the keys away. If you have the support of a doctor who can communicate this, not in an abrupt, disrespectful way, that's it, you're not driving, forget it, you're not even driving home from here. But someone who is trained to be able to compassionately explain why this is no longer safe. There's actually some really wonderful conversations that well-trained brain doctors can have with people about driving, and I'll probably talk about those in a future lecture, pardon me. We also can help people understand when it's safe for them to, okay, there we go. When it's safe for people to be managing their own money. A lot of times people can get taken advantage of. I can't tell you how many unfortunate stories that I've heard of, people who aren't legitimate coming to someone's door and saying, hey, if you write me out a check for $10,000, I'm going to come back and fix your roof tomorrow. Of course, you never hear from them. People calling on the phone saying, I'm calling from the fire department and please won't you donate $100. I mean, that's a really sad part of society, is that people do prey on older adults, and specifically when they have cognitive impairment. So a good evaluation can really protect against that. It's also a way to connect patients and family to greater resources within their community. One of the things that breaks my heart the most is to think of how many people are out there suffering with these conditions all alone in their house, that they don't have good quality support groups that they can go to, not have to reinvent the wheel, hear what's worked for other people, hear, what has not worked for other people. We need support. It really does take a village. We need to be able to connect with other people who have a shared life experience, because we are social beings. We need to connect. We need to be understood. That is such an important part of dementia planning. The other thing is that our medical providers are not sure what to do. They're not sure how to focus their treatments. There are disease-specific memory-enhancing medications that are on the market, and it's not the kind of thing where you just want to give them to everyone. But we also don't want to not give them to the people that they're going to benefit. So one of the most important things about a good evaluation is that then the person's primary care doctor or their neurologist will actually have instruction on what exactly they should be doing. We also have to be able to make sure that people's comprehension of their medical care and advice is actually being understood. A lot of people who have dementia, especially the mild cases and especially Alzheimer's disease, are kind of social magicians. They are really, really good at surface talk. Many times you would not know until you kind of look under the hood a little bit that someone is really struggling to connect ideas or to make sense out of what you're really saying. So if you just see a primary care doctor, once a year, twice a year, chances are these behaviors are not going to go noticed. What if then, as a part of that appointment, you're also then talking to the person about how very important it is to better manage their diabetes, and how really you want them to start to keep a book, that twice a day they need to measure their blood sugar, they need to write it down, something that has a fair amount of cognitive complexity. Good cognitive evaluations take this into account, and we can then advise people's families about something very simple, like you need to go to all the doctor's appointments because he's really not taking in what's being said. It sounds and looks like it is, but he's actually not. The other thing is that a good cognitive evaluation gives us a baseline, so that way we can monitor progression in both areas. We want to know what's working in terms of medicine, but we also need to know what's getting worse, so that way we can keep adjusting the information that we give to families and the person, and also keep adapting their treatment plan. Things that maybe worked in year 1 of dementia are not going to work in year 4 or 5. You have to find a provider that can constantly be flexible and think in new ways to best help the person. So let me share some information with you, as I like to do, to kind of get you more on board about why this really is a problem. So check this out. 50 to 65% of people who have been diagnosed with dementia have no documentation of it in their medical record. Now, I want you to think about what other medical condition would this even remotely be tolerated, okay? Can you even imagine if someone had breast cancer and you went and looked in their medical record and it was not in there? This would never, ever be tolerated in anything else besides dementia. caregivers have reported that it's typically taken over 2 years for them to receive an accurate diagnosis of their loved one's dementia. I think it goes without saying that unrecognized dementia is going to drive up costs of healthcare. It's going to lead to a lot more pain and suffering for the person and their family. We're going to have inappropriate and costly use of things like emergency rooms and walk-up clinics. And maybe most importantly, the burden of caregiving is going to be that much more. And I think what really, really bothers me is how unnecessary this feels. If we could just make the standard, the gold standard memory evaluation standard, if it could just be the norm, what is expected of people when they come in or their family comes in concerned about memory, so many of these problems could be reduced dramatically. Now, the truth is, we're not really that close to a quote-unquote cure for any type of dementia. But my God, these social things are things that we can actually be doing something about. And that's why I get so passionate about it. So when I heard these statistics, I wanted to understand what are the barriers towards the early and accurate diagnosis. And the research that I did came up with 8 specific reasons that I want to share with you today. So what they basically did was interviewed primary care doctors, because that's usually your first stop, right? This is kind of your quarterback of your care team, the person that you go to first, the first person that you interface with. And they basically interviewed people whose patients who had later gone on to be diagnosed with dementia. And basically they asked them in anonymous surveys, because you know that's how you're really going to get the truth, why is it that you didn't pursue a formal diagnosis or an assessment procedure? And this is what they had to say. So the first one is that they had doubts that it would help because there's virtually no or very limited treatment options. Okay, this is completely false. The next one is that they feared depressing the person. The next one is, and this one really gets me, is a tendency to minimize or downplay older adults' concern about their memory. Now, I know some of you are out there and have had this experience, so give me a thumbs up if you've had this happen or you know of someone who's had this happen. Basically, you go in with a concern, look, I'm noticing some things, I'm a little bit worried, and you basically get told, hey, look, you're 75 years old, okay? Not quite sure, what you want me to do about this, but look, things change as you get older. Everybody starts to go downhill a little bit. Well, if you know about dementia, you know that significant memory problems, specifically those that affect mood and behavior and affect everyday life, are indeed not normal. And I would take that a step further and say if someone is concerned, then that automatically gives them a right to a comprehensive evaluation because they are worried, okay? They are the consumer. The next one is just practice-related issues like a lack of time, not knowing who to send the person to. The follow-up appointments nowadays are typically 7 to 9 minutes. And when you go to primary care, I always have a list of things that I want to cover. My theory is that things that doctors can't see readily, basically the things I care most about, like cognition and mood, they're just not as accessible, and so they're just not going to be noticed as much. And so many people have that white coat syndrome, especially older generations, where when they go into a doctor, they want to present really well. They want to act like everything is great. The other thing, remember what I said before about that anosognosia symptom. Some people genuinely do not see that their memory is failing. So we have multiple problems with time and the radar of people who are seeing people who have complaints about memory on the front line. The next one, of course, is stigma. This is so huge. So dementia is hands down the most feared disease of Americans. I'm sure that's a similar statistic across the globe. If you ask older adults over the age of 50 what disease it is they fear the most, the vast majority of them will say dementia. People will tell you that they fear dementia more than they do another 9/11, more than they have a fear of snakes. This has actually prompted the American Psychological Association to theorize that in the next few years, we may actually have to create a new diagnostic anxiety disorder, dementia-related anxiety disorder, because we are just so consumed with fear of losing our mind. The final contributing factor are reliance on these cognitive screening measures, and that's why we're here tonight. So let's talk about what would be a good reason to try to use them if we use them in their appropriate way. Well, of course, a great idea is that we want to reduce subjectivity and increase objectivity, right? We want to go from people's opinions into some type of assessment that doesn't have a horse in the race, right? Something that doesn't have a long history with the person, something that, we're basically trying to take away the coloring of the lens, right? We want to distinguish cognitive impairment from normal aging, so a good screen should be able to do that. We maybe want to monitor someone's progression over time. We want to see how medications work or don't work. We all in the brain health field call these screening measures something called quick and dirty. And that is a really important concept for you to understand. So you can't do something quick and dirty anywhere in life and come out with a quality product. That's a great rule of thumb. But this applies even more in the brain, something as complex, the most complex thing that we're exposed to in our world couldn't possibly be understood within a 2-minute cognitive screen. There are so many contributing factors to cognitive impairment. Remember before I was telling you about the layered cake metaphor? We couldn't possibly distill it down to something that could be determined in 2 minutes. So I want to tell you about 3 different cognitive screening measures. One I think is pretty much garbage. The second one I would say is better. And then the third one is actually my personal favorite. So the mini mental status exam is something that has been around since 1975. People call it the MMSE. All allied health professionals are trained in this, from nurses to psychiatrists, and the idea is that it's a quantitative assessment of cognitive impairment. It's made up of 11 pretty simple questions or tasks that are grouped into 7 different cognitive domains. So we have orientation. The person is asked to remember 3 words. There's an attention task, a calculation task, which the person is asked to count backwards from 100 by 7s, which I actually think is really hard. Try to do that. I would fail that one. The recall of those 3 words, some language, and also some construction. It can take anywhere from 2 to 10 minutes. 10 minutes would be really, really long. But basically, there's 30 possible points, and the cutoff is typically thought of as 23 or 24, and that would give you the presence of cognitive impairment. There have been multiple criticisms of the MMSE, and despite this, it's still the most popular cognitive screening measure. The one that I think of so much in where I practice in North Carolina is its insensitivity to education and what we would call premorbid intellectual abilities. And really what this criticism is focused on is that you're going to get it wrong, get your conclusion wrong, in both people that are very, very bright and very highly educated, and also in people who maybe did not have such blessed life experiences and have low levels of formal education, or possibly are on the borderline impaired or low average level of intelligence. So the idea with the really smart people is that they're going to ace this test whether or not they actually have a real problem. The people who are really struggling, you're probably going to get a lot of false positives where they're going to come out looking very impaired, but they've maybe been somewhat impaired their whole life. And so there's no way within those 2 groups that this screening measure can really capture those 2 people, those 2 populations. The next one, of course, is it doesn't take into account in any way whatsoever sensory deficit. So, hey, how about if I can't hear what you're saying or I can't see what it is you're wanting me to draw? It's also very insensitive to something called executive dysfunction, which is a very common set of symptoms in different types of dementia. So it's really designed to try to capture early Alzheimer's disease, but of course we have dozens and dozens of subtypes of dementia, so it's not going to be sensitive to something like frontotemporal dementia or posterior cortical atrophy or Lewy body dementia or Parkinson's disease dementia or even vascular dementia. It's really, really pretty narrow in its scope. The other thing is there's no alternative version. So every time someone goes to the doctor, they're literally getting the same 3 words. I don't know about you, but I have had people make jokes about this with me. Oh, I'm going to go see that doctor. Okay, you know, tree, bread, foot. And they already know this going in. People also know very often, people are crafty, that you're going to ask them the year. I've seen people with crib notes written on their hands. The month, they want to know exactly who you are. People are smart. They don't want to be vulnerable. Again, remember how scared people are of dementia. This is a very nerve-wracking kind of an evaluation. After the mini mental status, we graduated in the most recent times to something called the Montreal Cognitive Assessment, also called the MOCA. Now, the MOCA is definitely an improvement because we have something called an education adjustment where you can actually add points depending on the person's education level. So that's kind of trying to even out the playing field a little bit. The idea is that it captures a higher proportion of people that actually go on to meet criteria for dementia, and this is because it has more varied cognitive tasks. So this actually has something on there. I think this is also on a 30 out of 30 points, but it's just not as narrow in scope. It offers tasks that you have to use different parts of your brain. It has more of the executive functioning skills, which are things like planning, being able to multitask, organization, those kind of things. It also has 3 alternative versions. It's published in 35 different languages. There's actually one for people with legal blindness, and it's free. It's freely available. The mini mental, I think when you buy a packet of 25, it's like $50 or something like that. So a lot of people love the MOCA, of course, because it's more accessible, more affordable. But my favorite cognitive screen is the clock drawing test. And I first fell in love with this during my time of training at Boston University, where the grandmother of neuropsychology named Edith Kaplan was training my mentors, the generation above me, that you should be able to conduct a thorough and valid cognitive exam on a desert island with some sand and a stick. She was not a big one for all these fancy computer tests, and she really wanted to be able to understand cognition on the most basic level. And that's really what I love about neuropsychology, is that sometimes on the surface it can actually look somewhat simplistic, but it's really, really complex in how it gives us information about neuroanatomy, in specific deficits, in different syndromes. It's really, really pretty savvy. So to me, one rule of thumb that I have is that you cannot make an accurate clock drawing and have dementia, and you cannot make an impaired clock drawing and not have dementia. I really find them to be mutually exclusive. So what I encourage people to do that I'm training is to get familiar with the clock drawing task, and all you need is a pen or a pencil and a piece of paper. So the idea is you make a big old circle and you just ask people to put in the numbers, and then we watch them, how they go about planning those numbers. There's a lot of different patterns that neuropsychologists interpret that tell us different things about different parts of the brain. We then have a secondary task in which we ask people to set the time to a very specific time, and we know that that is using a different part of the brain. And our idea, the way we work, is we put those 2 things together, and we can make very, very good estimates about someone's cognitive impairment, specifically about Alzheimer's disease. I think a clock drawing is also very helpful in doing feedback with patients and families because of that old adage, a picture is worth 1,000 words. Sometimes it's really, really true that the family so desperately wants you to get it, to be able to understand and make the accurate diagnosis and come up with a really good treatment plan. And sometimes when you show a clock that's really distorted, it's like, yes, that's it. That's what I'm seeing in my everyday life. One of the things I like about the MOCA is that it actually includes a clock drawing task. My criticism would be, however, that because 30 questions are fitting on one little piece of paper, the circle that they give you is teeny, teeny, tiny, and I actually want to give a big circle because it's kind of like giving more rope to hang oneself. I know that's a terrible metaphor, but the idea is you don't want to make someone's drawing better by actually constricting them and enhancing their planning. I want all the planning of the numbers to have to actually come from their brain. So let's talk about a 3-part solution to this problem with cognitive screening measures, because remember, one of my promises to you is that I will never complain about something without offering you a better solution. So the first one is that we have to recognize the proper role of these screening measures. And really what they should be doing is starting a conversation about possible cognitive impairment. Okay, it should be a way of taking it out of let's just talk back and forth into, okay, let me get a little bit more quantifiable here. Let me try to be a little bit more systematic and objective about what it is that we're doing. It also is a great answer to the question of should this person be referred to a specialist. But it has to be acknowledged that these are very decontextualized screening tests. It's really just a tiny piece of the puzzle. And the danger becomes when someone who is not extensively trained in the brain thinks that they can take that little bit of information and make a diagnosis, which will then come along with very specific medications and prognosis, and here's what you need to expect is going to happen to you in the future. You cannot get there from a screening measure. You just cannot. The second part of the solution is that we have to acknowledge that the ideal diagnostic process will always involve a team that communicates. How many people out there think that their medical providers should be doing a better job of talking about their care? Now, of course, we all are seeing a ton of patients and we're trying to take care of people the very best way that we can. It's not possible for us to call about every single patient, but there's certainly more times than not where I know the person's care will be enhanced if I pick up the phone and call their primary care provider. When we approach cognitive impairment from a team perspective, we're really then going to respect and welcome the contribution from each person in the team. I know that I provide the best care when I'm working alongside a very attentive primary care physician, when I'm working alongside a very knowledgeable neurologist. That's really, to me, the 3 tiers of the assessment team: a neuropsychologist, a neurologist, and primary care. There are, of course, a lot of other really important players once we get to treatment, people like physical therapists and speech and language therapists and all that, but we're just talking about the assessment process here. The third and final part of the solution is to empower yourself with the knowledge of what is a gold standard memory evaluation. Because if you just go to primary care, they, if at all, are going to give you one of these screening measures. But what I want you to know is, how is it that I can go in there and be armed with advocacy, and I'm going to be able to tell them, okay, that was a good start, but here's what I would like to see us do next in order for me to get the answers that I need to really move on and to have the best quality of life that I can have. So aren't you now, of course, dying to know what is this gold standard evaluation? Well, that is going to be my topic next week. You see what I just did there? I got you in and now I'm hooking you back in. There are actually 5 elements of a gold standard memory evaluation, and we are going to go through every single one next week. It involves physical exams, clinical interviews, laboratory tests, paper and pencil exams. We got to talk about how it all comes together. You will leave that lecture understanding exactly what it is that you need to ask for. Thank you guys so much for joining me again. I think these are pretty fun. I'm having a pretty good time doing them. I really appreciate when people tell me that it helped and that they feel more comfortable and they feel more empowered to go out into the world and ask for the care that they deserve. So thanks again so much, and I will see you guys next Wednesday. Bye-bye.